like actually. If you would like to use those, you can either click the CC button at the bottom of your screen, or if you don't see it, you can go to the middle um, button, which is the circle with the three dots. Um, or you can access it on a separate window. I will put that link in the chat.
We will be sending out the recording to people who register after. And we will also be sending out the slides that have live links in them and a resource sheet that also has all the links in one place, so you don't have to flip through. We do deny access for other people to record, and we do deny AI. Given the environment, we just need to keep a tight control on our information. So if anyone got denials, that's why. But you will get a recording um, and the slides. People still joining? Yeah, it looks like it.
Yeah. Almost faster than I can add them. Let's give it like 1 more minute and then we can go ahead
Okay.
and get started. Thank you everyone for being here and spending your Monday with us. We appreciate that. I don't see anyone else in the meeting room, so I think we should go ahead and get started. And of course, as soon as I said that, more people popped up.
Okay. Well, I'll go ahead and start. We appreciate everyone being here. So you were just hearing from Hillary Jorgensen, and I'm Julie Riskin, and we are the co-executive directors of the Colorado Cross Disability Coalition. And we've got a lot to go through. We're going to um, go through and um, tonight we're going to talk to the purpose of tonight is the changes that are happening in Colorado done by the Colorado General Assembly. We know everyone has the federal stuff on their mind, so we're going to touch on that. But we're going to talk about all of these changes that started July 1st, and what that means for our community, and also what are advocacy steps you can take to make sure that they work well. Some of these changes are things we don't like. Some of these changes are things we really, really wanted for a long time. And some of them are more neutral, but it's always important to have an advocacy voice. After each section, we'll stop for questions, but we might not have time to get to all of the questions, so we may be cutting people off and saying, okay, we're going to move on so that we can get to everything. Um, but if there are a lot of unanswered questions, people can also feel free to put them in the chat. We will make sure that if we have to have another one to answer questions, or we'll put out an FAQ or something. The other thing just to know is that some of these changes are really new. So there might be things where our response is we don't know yet, or this is what we think. We want to make sure that we're always giving accurate information. So we'll talk about the Accountable Care Collaborative, Phase 3. We'll talk about the Behavioral Health Administration, and we'll explain what each of these things are. We'll talk about Community First Choice. There's a bunch of other changes that are, we'll just kind of name what they are, but not go into them in detail. And then we'll talk about a couple other things that did not start July 1st, but that are coming soon. So to start with, we wanted to tell you who the Colorado Cross Disability Coalition is, because there are some folks here that we didn't recognize, which is fantastic. Welcome. We're very, very happy to have people who are new. We are a membership organization. We are 35 years old this month. And if someone from staff could put the invitation to our birthday bash in the chat, we celebrate our birthday along with the Americans with Disabilities Act. Um, and our focus is on changing systems. That's what we do. Everything we do is in service of changing systems. And we do that by building power. That's our mission, is to build power in the disability community. And with the power and influence we build, we advocate for social justice for people with all types of disabilities. And that's what cross disability means. And we break down barriers, any barrier that prevents us from fully participating and being part of the world is a barrier that we want to break down. And our vision is fairly simple. It's that people with all types of disabilities will achieve financial, political, and social equity. So that's, and again, membership is free. It's open to anyone who believes in our mission. You don't have to have a disability. The more members we have, the more power we build. So please join us as a member if you haven't. The other benefit of being a member is you get information like this directly and immediately. And whenever we know something, you know something. Whenever there's an action to take, we will let you know. So the federal bill. We're not going to spend a lot of time on this. We're going to do a town hall just on this once we wrap our head around everything that's in there. Some people call it the big beautiful bill. Some of us are calling it other things that I won't put in print. Other people are calling it the bad betrayal of a bill or the big ugly bill. It is a huge bill that was rushed through Congress very, very fast. Not even the people that voted on it know everything that's in it. So when we say we don't know, there are people that do nothing but study federal policy and look at this. They don't know what's in it. It went through the House, like literally passed in the dead of night, then very quickly went, I mean, sorry, then it very quickly went to the Senate. They made changes, again, also kind of in the dead of night. And then it went back to the House where they voted on it. So we don't know every single thing that it means. What we do know is that something called a provider tax, which is the hospitals pay money to the state. The state then can use that and the federal government matches it. So if the hospitals pay the state $100, the state then gets $200 because the feds give us another 100. The way it works is then the state gives the hospitals back maybe like 120, and then that other $80 pays for other things. It pays for the Medicaid expansion, and it also pays for the Medicaid buy-in, which is so that so not the so that tax is over a number of years going to be cut in half. So that's very, very scary. There's also work reporting requirements, and I think it's important that we say what they are. This is not about getting people to work, it's about getting people to report work. Um, People who are in the expansion population, which is people who get on Medicaid not through their income, not based on disability, but many of them have disabilities. Um, those folks will have to show that they work 80 hours a month or are in some other form of community engagement, which could be volunteering or school. Anyone who does redeterminations with Medicaid, I think will understand the problems with reporting. We actually put out an editorial saying we don't have a problem with work at all. We have a problem with excessive reporting and a one size fits all. We have a work requirement in the buy-in program, which CCDC supports, adamantly supports. But more times when people have to report into our broken system is a problem. It's also going to cost Colorado taxpayers, I believe it's either 57 or 59 million just to implement this. There's also going to be some cost sharing requirements that are very unclear as to what they mean, and that those are generally seen as copays. The law says it's unclear. It says up to $35 per service, but certain services are unclear what they are. It's a little unclear also who, if this only applies to expansion or if it applies to everyone. Um, so, so anyway, there's a lot in this bill. There's lots of other things in this bill that affect other um, that affect other things. There's a big cut in food stamps. So there's a lot here. So what we're going to do is, first of all, we're going to analyze and share a more detailed impact statement, exactly what it, and that's going to take us a few weeks. Hillary and I and other people on staff are going to a lot of meetings with federal partners, people again who are putting all of their time into figuring this out. to figure out what it means. And they also were, it's all implemented at different times. Some stuff starts in like the work requirements, work reporting requirements start in 26. The provider tax starts in 28. So we'll outline what happens when. What, regardless, it's going to hurt our state Medicaid program. So that also means that we need to, we've already been doing Medicaid sustainability work. We're looking at both where can we find other revenue and where can we make cuts that we can live with? Because even without this, our state was already in a budget crisis. So we're going to have to make some changes in Medicaid. And we think it's important that people with disabilities have a say in those. We're already doing that. We will continue to do that. We will also, through our grassroots work and possibly RC4, be doing a lot of accountability with our members of Congress that voted for this. Um, and making sure that all of our members of Congress understand their responsibility to all of us, including people with disabilities. And then finally, we're going to be helping our community manage the impact. And so that'll be doing things like creating tools, working with providers and creating tools to help people either report their work or get an exemption. And the reason I say work with providers is there are not enough advocates for advocates to be helping people like this. It's going to happen through providers. So we will work with providers because it's in their interest that people don't fall off Medicaid to help them. And then when there's complicated situations, we'll help with appeals on those things. So this is where we're at. No one's happy about this, but this is kind of the response that we are going to make. Along with many other partners. And I want to thank, I know lots of people on this call did, worked hard, made your calls, and we're going to need to continue to do that. Because this is, and basically, elections have consequences. We have another one in 26 and another one in 28. This is the stuff that we have to think about. Are there any questions before we get, and again, we don't know much yet. But if there's any burning questions, I don't see any. So we'll move right into Accountable Care Collaborative 3.0. So first I'm going to say, what is ACC and what is Array? Because one of the things that happens in healthcare and in bureaucracy and government is people have to make up a new acronym like every 15 minutes. So ACC is the Accountable Care Collaborative. Every state Medicaid has to manage the care. Like there's over 1 million people on Medicaid in Colorado. So it can't just be like everyone just does their own thing. It doesn't work. So the Accountable Care Collaborative is what we do here in Colorado, and it's a better way than the other what some other states do. Generally, states can either do this, which is where they're organizations that help coordinate care. They have the kind of help make sure that people have primary care and that they're care coordinators. The other option is strict managed care, where a company comes in and says, okay, we're going to control who the providers are. We're going to decide what you can get and how much, and everything has to go through us. This is more of what they call managed fee for service. And we like, at CCDC, we like that better because a lot of the people that we work with don't need, like they might need to see specialists or they might need to see, there might be this one provider that helps with a certain thing. And there aren't that many of them, so we don't want to be in a narrow network. Now, there are two managed care companies in Colorado. One is on the western slope. Some western slope counties are in a managed care that's run by Rocky Mountain Health Plans, and Denver Health also runs a managed care program. So we do have some of it, but it's people don't have to be in it, and people don't have to be in it. They can opt out, and most of it is not managed care. So when people have said, why are we even doing this? It's because care has to be managed. And a lot of people in Colorado think this is preferable to the alternative. In other states, they've basically turned over their Medicaid program to for-profit managed care companies. And from my colleagues that I've talked to in other states, it has not been a good thing. So what is Array? Array stands for Regional Accountable Entity. And those are the organizations that manage care. So it's a little confusing because for physical care, like doctors, like your primary care physician, physical therapist, hospitals, x-ray, lab, medication, that's all fee for service. And the Ray, who you might never even talk to, like many people will never even talk to their Ray. But what the Ray can do is they can help, first of all, they can get you a primary care provider. And and everyone gets attributed to one. I'll talk about that in a minute. But you could go to any primary care provider that takes Medicaid. But then if you're having trouble, like let's just say your primary care doctor says you need to see this specialist and you can't figure it out. You're saying, I can't find one, or the one that you told me to call, has a 12-month waiting list and my doctor says I need to see him now. These care coordinators will help you. That's what they get paid to do, is to help you find a specialist, do those kinds of things. They can also help if you're having problems with our transportation system and Telluride. A lot of people have problems with them. They can help with that. They can do a broad variety of things to help someone who's struggling with that. So why they're called a regional accountable entity, I don't know, but that's what they're called. And why is it ACC 3.0? Well, because this is the third contract. They started out with the first one, and in those days, the Rays were called something else. Then they went to the Ray, and that was the second one, and this is the third. And so this contract goes for 7 years. So that's what an ACC and a Ray is. So who are the Rays? One of the big changes is there used to be 7 Rays, and now there are 4. Um, when you get this slide deck, you'll be able to click on the link and get to the site, the website of each of these Rays so that you'll be able to see. And there's also a map in here on another slide to see where you are. So Ray 1 is Rocky Mountain Health Plans. They cover the entire western slope, all the way south, Hook and Pueblo, and all the way to southwest to the Four Corners. Region 2 is the other side of the state. That's Northeast Health Partners. They cover all of eastern Colorado and Northeast, and it goes into Larimer. They get Larimer too. Region 3 is Colorado Access. They have the fewest counties, but a very large population. They're Denver, Adams, and Arapahoe County. And then Region 4 is Colorado Community Health Alliance. And I always say they're like kind of the three-quarter donut around Denver. So they do Boulder, Jefferson, Colorado Springs, and a few other counties like in that little circle. Those are the Rays, and they will be the Rays the plan is for them to be the Rays for the next 7 years. So what's changed? What's the difference between how it was before July 1st and what it's like now? One is we went from 7 to 4 regions. The areas that have a new Ray are actually fairly small. The biggest changes are Pueblo and San Luis Valley moved to Rocky Mountain Health Plans. There used to be another Ray that's no longer here that served them. Larimer moved from Rocky, they're no longer with Rocky Mountain Health Plans, and they're now with Northeast Health Partners. Most other people, it's the same one that you've always had. Um, we also changed how we do what they call attribution a little bit, not as much maybe as would have been nice, but a little bit. So the way they've done attribution, meaning which Ray are you in? How do you know? Because sometimes someone will say, well, I was assigned to this, someone might live on the West Slope and they say, well, I was assigned to Colorado Access. Why is that? The way it's been is that you're assigned based on your primary care physician and the place that you've most recently used healthcare. So if you live in Grand Junction, but you've been in residential treatment in Denver, you probably went to a doctor here. And if you've had several claims here, you might be attributed to a doctor in Denver, and then you'd be attributed to Colorado Access. Not a big deal. You can still call and get reassigned to the place when you go home. So initially they're going to assign based on where you've gotten health care. But if there is no health care history, or you're new to Medicaid, they're moving to try and assign based on address, which we think makes more sense because then if you're in one place and you're somewhere else for treatment and you're coming home, it's the place in your home that's going to be able to better care coordinate. So, for example, if you live in Grand Junction and you get treatment in Denver, you're then coming home to Grand Junction. You really want Rocky Mountain Health Plans to be doing the care coordination because they're going to know the resources, whereas Colorado Access would certainly be willing to help, but they're not going to know the Grand Junction resources. So they're making a transition there. Another change that I think is really positive is instead of saying care coordination for all and then telling the Rays, do these 800 things for everyone, and quite frankly, doing none of them really well, and whether you need them or not, they're doing tiered care coordination. So care navigation is kind of prevention, the lowest level. So that would be something like when the pandemic hit, making sure they were doing outreach to tell people where they could get a vaccine if they wanted to, or sharing information, like sharing information, even just stuff about how to be safe in the 100-degree heat, whatever. That stuff is for everyone. Being able to answer questions like, I don't have a Medicaid card. Do I need one? Or how do I get Medicaid transportation when really maybe all they might need is a website? Very basic stuff that everyone gets that and everyone should. Then there's care coordination, which is done really for chronic diseases. So if someone is struggling, let's say they have diabetes and they're struggling to manage that, there's really good protocols for how to manage things like diabetes and asthma and other chronic illnesses. That'll be care coordination. You get care coordination around a specific disease. Now, lots of people have disabilities and they don't need that. They manage it just fine. They don't need that. So rest assured, no one's going to say, because you have this diagnosis, you have to go talk to some person. It's really, if you want it, if you're struggling, you'll be able to get it. And there'll be a little bit of a higher priority for folks with some of these specific diseases. And then finally is care management, which is the complex, the highest level. And that's where you would get the most attention. There are a small number of people that need that higher level of attention. But if you tell these organizations, these Rays, you have to do everything for everyone, they never really have time to get to those small number of people, but who have very significant health problems to give them what they need. So this is a much better approach to say, let's have some people get a lot, some people get medium, and then some people will get just really information. The other thing that's cool is there's more client involvement mandated, which at CCDC we always think is a good thing. So in the past, each Ray had to have what's called a PIAC, which is Program Improvement Advisory Council, which is a council that involves everyone. So it does involve clients, but it involves hospitals, community leaders, mental health providers, doctors, all kinds of different people. And then there's what they call MIAC, which we just call client councils, which is a council just for the clients, advocates, and families for those issues. And now each one has to have two. There's some more requirements on how much attention they have to pay to them. And so they have to have two of each. And in some areas, that's really important, like Rays 1 and 2 cover gigantic areas. And you can't just have one, for example, the whole Western Slope and Southern Colorado. That's not fair. You can have, so that way they'll have two. There'll be one in the southern, one in the west. And so they have to have two MEACs and two PIACs, and every Ray also has to have a health equity council. So those are some of them. And there's also a new contract. We put in the slides for people that think reading government contracts is their idea of a good time. And I know there's some of you here. We put the new contracts, the link to the contracts in the slide. Um, what is a health equity council? It's basically a council that's going to focus on health equity issues. So are certain groups being disadvantaged by systems? And so they'll look at data and look at, is there something we need to do to make things more equitable? For example, there's a lot of, and there might be things where like you can't always control it. So there's a lot of equity concerns in rural areas. So you might say rural people are waiting 4 months longer to get into a specialist than urban people. That may or may not be something that they can fix, but it's important to know that to see if there's something they can do. Maybe the answer is we beef up transportation. Maybe the answer is they get a mobile, for certain specialists, they get like a mobile van to come to communities more often to make it a little bit more fair. Sometimes language access is a really big deal with health equity. If people with a certain language are saying, I can't find anyone who can treat me, then what are we doing in terms of A, recruiting people who speak that language or use that language, but also having interpretation? So those are examples of health equity. And there'll be a council that looks just at that. Now, that doesn't mean that the other councils shouldn't deal with it. Of course they should, and they will, but there'll be a group just for that. And I assume that most of the Rays, if not all of them, will have members from the other two councils look at um, be part of the Health Equity Council as well, so that there'll be coordination. Um, so someone asks, what is the potential impact of a person on a Medicaid DD waiver relocating from one ray to another? None really. One of the cool things about a ray versus managed care. So let's just say you're in a ray and you get attributed to a provider. You get attributed to Health Center ABC. But you like to see Dr. Jones and Dr. Jones takes Medicaid. It's okay. You can still see Dr. Jones. You don't even have to ask permission. You don't need to do anything. You can choose to call Medicaid and say, I want to be attributed to Dr. Jones, but you don't even have to do that. You can still see whoever you want as long as they take Medicaid. So if you move, you would probably want to call and say that you want to be in this other region because they'll be able to help you better, but you don't even have to it'll catch up with you when you do your Medicaid address change. So there's no problem at all with doing that. And that's part of why we like this is that you can still see any provider you want. You don't have to see a specific provider, even if you're attributed there. The other nice thing is that they have to find you a primary care provider. So you're not totally on your own. If you can't find one, they will find you one. Um, so I'm going to move on to behavioral health. And I'm now going to talk about non-Medicaid for a minute. We often talk about Medicaid, going to talk about non-Medicaid. So the Behavioral Health Administration was formed in 2022 with House Bill 22-1278, which was a giant bill, but it did have a lot of debate and a lot of hearings and lots and lots and lots of meetings. And there's been a lot of work on the rules going forward. The BASO, for another acronym, stands for Behavioral Health Administrative Service Organization, was created to be the single point of entry for all behavioral health. And so and again, this is non-Medicaid. So, and I think I forgot to say, I got carried away with the ACC. Let me jump back to the Rays for a minute. The Rays do care coordination for physical health, which is fee for service. They also do all mental health, which is more like managed care. It's capitated. So they actually fully manage the mental health benefit where you have to go through their providers. Every Medicaid provider is enrolled with every Ray, but they manage mental health totally, more like a managed care program. So we're now going back to BASO, the Behavioral Health Administration. We're not going to talk about Medicaid. This is for everyone else, for people who have no insurance or who have really bad insurance or have like what they call underinsurance, like they might have just a high deductible plan or a health savings account where they don't really have access to get mental health care in any other way. People on Medicaid do have access to get mental health care. So what this did is it took crisis services. We've had Colorado crisis services for quite a few years. It took substance use disorder services, which are newer, and then it's regular mental health for uninsured and underinsured. And it kind of combined two different things, which is called like a managed service organization, which is where you directly contract and you manage all the care, and the administrative service organization, where which is more like what Array is, where you're just administering it, and then put it into this thing called a BASO. And so what the BASOs do is they will be where someone goes when they can't find mental health. Now, if someone's on Medicaid or Medicaid eligible, what the BASO is going to do is they're going to send you back to the Ray for Medicaid because there's not, the BASO is totally state funded. And if you remember, I said we have a $700 million hole at least, and it might be more. So we need to make sure that we are preserving every single penny of state money and not using that for anything that someone can get elsewhere. If you have private insurance that does have a mental health benefit, they might say, here, let's go here. And maybe they'll refer you to the division of insurance if your insurance is not paying for mental health because they're supposed to be. But if you don't have anything, that's what they're there for. To the extent that the money lasts. So it's not going to be an entitlement like Medicaid. So it's not if you need it, you automatically get it. It's going to be, we're going to do our best with the money we have to make this happen. If we are also looking at possibly having more uninsured people, given the federal changes. So we want to be really, really protective of this money in this program. So that's why I have on the slide, keep expectations low, because they're not going to be able to be all things to all people. We the regions are the exact same. We fought really hard for that. Initially, they were going to have totally different regions between the Ray and the Basso, and we fought really hard to have the same regions because we did not need things to be more confusing with different maps. So there are different providers though. So in Region 1, West Slope in Southern Colorado, it's the same organization. It's Rocky Mountain Health Plans. Regions 2, 3, and 4, the BASO is all a company called Signal. Signal's a good organization. They do just mental health, and they are working very closely with all of the Rays. And I put the link to those organizations in here. So if someone, so let's just say someone is in crisis and they're Medicaid eligible and they show up at a BASO. Well, if someone's in crisis, the BASO is not going to say, well, you have to go to the county and do a Medicaid application, or you have to enroll in Peak, because you don't do that to someone that is in a mental health crisis. That's just mean. So they're not going to do that. They will help the person enroll and support them, or maybe send them to someone who can help. They'll make sure that they can enroll, get that, but first they're going to get them the help. They're going to get them that emergency crisis help, get them a little regulated, then help them enroll, then transition them back to the Medicaid system. So it's important that we all support their effort to enroll eligible people because their funds are more limited. The other thing that the BHA did is it created a new provider licensing, and it aiming to increase the quote unquote safety net providers. So there's two different kinds. For many, many years, the only quote unquote safety net providers in mental health were community mental health centers. And they're still going to be around, but we're going to have more choices. So there's comprehensive providers and essential providers, and they each have different things that they do. And their license, when they get their license, they identify what they're going to do. The comprehensive have to do more, and the essential don't have to do every single service. But when you're a safety net provider, there are some expectations that you don't get to kick people out because they're difficult. You have to be part of a grievance process, those kinds of things. Again, there's a lot of advocates that have put a lot of work into these different rules, but the whole idea is we need to open this up. We can't have in any system, no matter what, one protected group of providers that isn't really accountable. We want to have competition. We want to have choice. We want to make sure that people, and again, I know that there's not going to be choice everywhere. There are parts of the state where there's just very little providers, but we want to have as much choice as possible, and we don't want there to be any sort of monopoly. So, but this is very new, so we'll see how well it works. There are going to have to be tweaks as it gets rolled out and implemented. But I want to make sure that people don't expect as of Friday that you can go to these BASOs and that they're going to be able to do all things for all people. They've been working hard to get ready. They didn't have their contract until 4 business days before July 1st. But they have been preparing for months. And there's a way to be involved. There are public meetings they also will have councils, and these are separate councils. These councils are different than the other ones I talked about. So if you're really interested in behavioral health, you might want to look at one of these. Even though there's one organization that does 3 regions, they're going to have a separate council for each region. And so there's information sessions. Well, one of them is tonight for Region 2. But the others are all later in the month. And again, if you live in Region 2, which is Eastern Colorado, I'm sure you could show up at 3 or 4's, 3 or 4's events because it's the same organization, or you could just reach out to Signal. The application for all of the councils is linked and you'll get it. And we really want to have good people apply for these because it's important. They are mixed councils. They will have providers, other people, but they do have seats for people with lived experience as well as family members and advocates. We are also trying to push hard to make sure that lived experience means people who have significant issues in the public mental health system, to make sure that we're really hearing the voice of the people that are often most left out. So I don't see any questions on BASOs. So we will talk about community first choice, which has more meat in it. Community first choice is a section in the Affordable Care Act that we have been trying to implement for a decade. It moves some services from waivers to state plan and gives the state an increased federal match, which is very important on those services. So let's start by saying, well, what's state plan and what's a waiver? As the state plan is what most people know of as traditional Medicaid. That's the medical part. That's the part of Medicaid that pays for a doctor, a hospital, therapy, medication, wheelchairs, stuff that generally that's medical that a doctor prescribes. That's state plan services, it's the medical care. It also includes things that are not really medical, like it includes transportation. Dental is in there, but it's generally what you might get in insurance, although with Medicaid, there are different rules, so it works a little differently. But the stuff that you would get in a health insurance plan. Waivers are long-term care. And long-term care are things that you need every day or most days to function. So long-term care includes personal care, skilled home health, even like private duty nursing, even though that's medical, that's kind of seen in the long-term care world, non-medical transportation, day programs, even assisted living as part of long-term care, community connectors for people in the developmental disability system, home modifications, all of those things are in long-term care. Long-term care are things where you have to meet with your case manager, usually twice a year, and they do a assessment to see if you need a level of care, and you do a care plan, and they're always prior authorized. That's what long-term care is. So community first choice affects anyone on Medicaid who meets what's called the institutional level of care and using one of the affected services that I'll talk about in a minute. I want to make sure I'm clear about an institutional level of care, because whenever I say that word, it freaks people out. Does not mean that you have to be in an institution ever for 1 second. What it does mean is that you qualify using an assessment that the state does, that you would qualify to be in a facility because you need help with activities of daily living. So that means that you need help with things like bathing, dressing, eating, transferring, or that you have a cognitive disability or mental health disability and you need help with something like reminding you to take a shower or helping you problem solve on a very basic level, or cueing to say, okay, here are the steps you have to take to do these tasks that most people know how to do. That's what an institutional level of care means. It just means that you meet you have problems in those areas, not that you ever have to go to an institution. I wish they would change that word, but that's what the law says. So you go through an assessment, you meet this level of care, and that means you're at a quote unquote institutional level of care. And then in Colorado, you say, okay, we in Colorado want people to live in the community, not in institutions. Therefore, we have all these programs that are called waivers. And there are a number of different waivers, and these waivers provide all of these other services that help people live in the community. So everyone is not going to jump into this on July 1st. What they're going to do is for people, so if anyone applies for any of these services today, they will go right into community first choice. For everyone else, when they do their regular redetermination, if they're using an affected service, that service moves to community first choice. For many people, there will be no difference. They're not even going to really see it, but there are a few areas where they will. So the services that are going to go into community first choice, the one that's the biggest is personal care. And that there's personal care can be provided through consumer direction, through in-home support services, or through agencies. Agencies that provide it have to have a certain kind of license, and there's a memo linked in the chat. Health maintenance activities, which is a term that we use in CDOS, Consumer Directed Attendance Support, that has to do with care that would have been provided by a certified nurse aide in a home health agency. It's certain kinds of tasks, or a nurse. Home delivered meals, homemaker medication reminder, which is the machine that you get to remind you of your medication. The personal emergency response systems that I always call the I've fallen and I can't get up buttons. Remote supports, which is relatively new, and transitions. All of those services are moving to the state plan. So the question is, so who cares? Well, we care because we get more money from the federal government is one big reason we care. It also adds something that we've wanted for such a long time, because what Community First Choice mandated is that they cannot limit self-direction. They have to offer self-direction for everyone. We have never had self-direction for people under the age of 18, and we will have that now. It also says that there's no longer a distinction between a relative provider and a non-relative provider. In the past, and this is really important, in the past, family member providers, a legally responsible family member provider who, and a legally responsible as a parent or a spouse, could only bill for 40 hours a week. That's changing, but I want to be very, very cautious about this change. As I've said a number of times, we are in a state budget crisis that's going to get worse. Everyone is looking at what are we doing around Medicaid, because there are parts of the Medicaid budget, including long-term care, that are growing really, really fast. We've created a system that is overly reliant on family caregivers. I think if people go from billing 40 hours a week, they get on this program and they're now billing 80, we are going to risk the ability for family members to get paid for everyone. Legislators are going to see that and they're going to say this is a problem. So I think it is really important that we as a community use restraint and don't explode things with this, because it's going to cause a problem if we do. People are already looking at this. So I think it's really important that we preserve this right that has been life-changing for so many people, and not blow it, and that we ask our friends and colleagues and our community to do the same. I'll get with you 1 second, Jose. There are also a couple other requirements. One is no one person, no matter relative or not, can work more than 16 hours a day. That's safety. That's not unreasonable. You cannot provide care safely if you're doing it for more than 16 hours in a day. You also, they're not going to allow more than 10 hours a week of homemaker provided by a legally responsible person. Homemaker has always been pretty limited for if there's any non-disabled person in the house anyway. But now they're going to say that's a limit for a legally responsible person. If you need more than 10 hours a week of homemaker, which again, most people don't get, I don't think, but if you need more than that, you can have it. You just can't, it cannot all be provided by that specific person. It could be provided by another family member. The other thing that's really cool is that in the supportive living service, because personal care is being moved out, there's no more SPAL, which is a service plan authorization limit, which was a huge limit. You're going to be able to get the plan that you need. That goes away. Um, as does the whole over cost containment thing, but people are still going to have to be assessed. Jose and then Hillary.
Thank you, Julie. Can you explain a little more what you meant with the second part of the explanation about the relative difference rule that used to be 40 hours per week and now it's not? What were you saying about using restraint? I got lost for a moment there.
What I meant is if someone is getting care and a family member, they're getting paid for 40 hours a week and they've been getting paid for 40 hours a week for years. And then they get in this program and they're now billing 80 hours a week. That's not going to look good. That's going to be a bad look. That's going to make policymakers think that we're taking advantage of the system. Now, does that mean that someone maybe couldn't bill 42? Because I know a lot of people are actually working more than 40 hours a week. We all know that. But if we blow this up, we're going to get very strict limits. We have a more generous limit than almost any other state. Hillary?
We have a lot of questions on the chat.
Oh,
Do
okay.
you want to hang on to them or do you want to do this now and then move on?
Um, hang on to them for one sec. I just want to go through what
Okay.
is not changed and then I can answer, but thank you.
Yep.
So what's not changed is even though this is now, these services are now in state plan, you still have to go through your case management agency, not the RAY, your case management agency for the level of care. So you still have to meet that level of care, even though it's a state plan service. You still have a choice to self-direct or not if, and this is a big if, there's a provider. We're hearing more and more from people who say, you know what, I would really rather not self-direct, but there is no one, there's no way to get care other ways through an agency. But if there's an agency, you can still use an agency. Everyone must be offered the choice to self-direct, but no one's going to be forced to do that unless it's because there's no other provider. And you still have to be eligible for Medicaid. And you can be eligible for Medicaid through all the ways that we can be now. There are some people that their eligibility for Medicaid comes through being on HCBS. So that's important. So let's just say that the only service you use is personal care in your waiver. And now that's part of the state plan. But your income, you don't work, so you're not on the buy-in, and your income is over the Medicaid, but it's under the 300, the 3 times SSI, which is the criteria for waivers. Well, what the state did, and this was great, is there's another benefit that's called, I think it's in a later slide, like it's something about health and wellness where they basically send a newsletter. So that'll be your waiver service. There'll be a newsletter about health and wellness that you'll get. So people will still be able to be in a waiver if they need to be, because this was never, no one wants any wellness education benefit. Thank you. No one wants anyone to not have Medicaid because we're making this change. That was never the point. So so I wanted to say that. So, um, the, let me go to the,
I can link them to you if you
okay,
want.
thank you. That would be
Yeah,
great.
that goes a lot. Okay, so when you were talking about when people who are currently on Medicaid would be eligible for CSC, not new. If someone did a research, for example, on June 28th, right before CFC kicked in, they would not be eligible for CFC until June 28th, 2026,
Yeah, I mean,
correct?
all research are by the month. So I'm actually in that group that's going to be the last because my research is June. So all of us who research in June won't be eligible. Everyone who so like if you did your recertification visit on June 28th, you would go into CFC because that would be for a July, that would probably be for an August start. But yeah, so whatever month, it's always by the month. So
Um, is there a final CFC direct care services calculator? And if so, can we please send out the link
um,
ahead?
of course there is not. There's an interim direct service calculator. And that will be in that's in one of the links that we have. The interim one is what we use now. It's very similar to the CDOS task sheet for people who are familiar with that.
Is Homemaker enhanced too?
That is a good question. If Homemaker enhance, I'm gonna have to get back to you on that because it's not in my list of services, but that doesn't, does anyone know that doesn't totally make sense that it's not there? Um, but I can get back to you on that if someone can take that down. I know that
Yeah,
there's a lot of discussion about Homemaker enhanced.
yeah, I'll write it down and we can
Okay,
get back to
thanks.
you. Um, how can we enhance the mental health to allow permanent employment support services as well as community VSP workers for those who have IED and mental health but don't get SLS?
Okay, great question. And just DSP is direct service professionals. Um, and so that's a really great question. And I think, so are you talking, if you're talking about Medicaid, that's really about uh, getting a supported employment benefit. I think with Community First Choice, one of the beauties of that is that you will be able to use personal care for things like support at work. Now, if it's true supported employment, that's a benefit that we need to get for people outside of SLS. And the DD waivers that should be in the mental health waivers all should be actually in all of the waivers. And But with personal care, if someone needs a little bit of support at work, you can use personal care when you self-direct to do it on the job. So that's absolutely um, a beauty of this. I think acknowledging that people might need more mental health support to be able to work is huge and something that our system has not done well and something that we need to continue to do. So I don't want to sound glib like, oh, just hire a personal care provider and that'll be easy. It won't be. But I think that's a stopgap for now while we can work on trying to figure that out. I also think that as we're looking at these things, we need to make sure as we're asking for new things like supported employment, we also might want to look at, so what do we give up? So maybe it's you can either have supported employment or a day program, but not both. And that's just off the top of my head because it's going to be a very long time before we're going to get anything new given our budget situation. So if there's something that we as a community and after a lot of discussion and input decide this is more valuable than that, or people could have maybe a budget and then they could choose what they wanted to do with that budget instead of this service for this waiver and this service for that waiver, those would be workable changes, but we're not going to be able to just keep adding. But that is definitely an area where there's a lot of need, and this will at least give some relief.
Someone is asking a clarification on the homemaker. So can you summarize what changes are affecting the homemaker and homemaker enhanced? I am not understanding.
Okay, the enhanced I'm going to need to get back to you about because I'm not 100% sure. But with the homemaker, the only change is that a legally responsible relative can't be paid for more than 10 hours a week. You can get more than 10 hours a week, but if you're the legally responsible relative, you're going to have to find a second person to do those additional hours.
All right, we have one more.
Okay.
People who are on CFC under the income and asset limits of Colorado long-term care. If yes, then CFC is part of long-term care, not part of state plan. I guess it's a statement, not a question, but
It, yeah, it shouldn't matter. If you're under the income and asset level, it really shouldn't matter. So I'm not sure if there's a question, but if you qualify for Medicaid, CFC isn't a program, like you're not on CFC. Your CFC is a delivery method, really, and it's a way of doing things differently in Colorado. So you're on Medicaid, and you're either on regular Medicaid or straight Medicaid, or you're on long-term care Medicaid. And the way you get into those is either through you have SSI, you meet level of care, and your income is under the 3 times SSI and your assets are under the 2,000, or you're on buy-in. Those are the disability ways to get into Medicaid. You can also be on what they call MAGI or expansion Medicaid and have these needs. You could be on MAGI and need personal care. So that's really how you want to look at it. It's just if you don't need to be on a waiver, you don't have to be anymore. But if you do need to be on it, they've made it so that's going to happen pretty seamlessly.
Julie, there are people asking about giving up waivers to be on CFC. Because CFC is a benefit, you don't actually have to give up your waiver.
Right. That's why they created that health and wellness benefit. If someone didn't want to be on a waiver, like nothing would change. Like if you say, I don't want to be on a waiver, okay, nothing is going to change. You still have to go through your case management agency. You still have to do the same assessment. There's really no change in your life, whether you're on a waiver or not. But you could, it just doesn't matter.
That is the end of the questions for now.
Okay. Um, so a few other July 1st changes, because we like to do everything all at once in Colorado. Peer services, which is something that has been in the mental health and the substance use space. There are some changes to who can provide that, and they are limiting who's going to be able to provide that as a response to some abuse of that service. There's also a whole new system of care as a result of a lawsuit, and I put a link in there to get more information that says kids in very extreme situations are going to have to get a certain type of service and be offered certain access to services like wraparound services and different higher level of care coordination. There are new contracts for all of the case management agencies. Nothing substantially different, but there are new contracts. 2 children's waivers, which used to be the Children's Home and Community-Based Services System, CHCBS, and children with life-limiting illnesses, which at one point was called the hospice waiver. Those have been combined. Again, everyone who's eligible for still eligible, but it's now called Children with Complex Health Needs waiver. So if someone says, oh, you're not in for these children, oh, you're not in this waiver anymore, just a different name, just having fewer of them. That's something the state's been trying to do for a while, is do we really need so many? Could we have fewer and still serve the same people? Something that is going to be seen more and a bigger deal is they have reinstated prior authorization for long-term home health and private duty nursing. That got stopped. It's a long, sordid story. Got stopped, tried to restart it. That didn't work. Stopped again. It's now restarted. One of the things that they found is when it was stopped, things went crazy with like a lot of increases. So sometimes we found the same thing when they stopped the prior authorization for outpatient mental health, that all of a sudden there was just tons of increased spending. So they do have to reinstate those, but it's also important that we as advocates watch and make sure that they're being done properly. And then the last acronym is ISLA, and that is that for people in the DD waiver, they had to do a SIS, a supports intensity scale. And that the ability to do that went away in June. And everyone who is in the system now, who has a SIS level, people in the system will know what that is. They will continue to have that SIS level. If they feel like their needs have changed, they can get what they call a support level review. That will be this, that they will be able to do that process. This is just for new people coming into the system. And this is a interim support level assessment. Why is it interim? Because the state is actually working on a real comprehensive assessment for everyone that would be a full assessment and create a budget process, a budget, an individual budget for everyone. That was supposed to have been done a couple years ago. We are several years away from that really happening. So we had to do something in the interim because we could not keep using the SIS. And so that was what we did. And people who are involved in that process of developing this ISLA feel pretty good about it. They feel like it's a pretty fair process and a pretty good process. I am not an expert in that. We have other people who are more of an expert in that. Two things that are coming soon, but not in July. So I'll start with the nurse assessor program. That we have a whole work group on that. So if people are really interested in that, you can let us know and we'll have the person who's running that, his name is Bryce, get you on his list. But the nurse assessor program is going to be an assessment for all skilled care, and that's CNA, like CNA and above level care. And they're having these nurses do these assessments. Some will be in person, some will be virtual or remote. And we agree that there needs to be an assessment. We have some grave concerns about the process and about the people doing the process, if they really understand community-based care versus institutional and medical model-based care. We also have a grave concern that all of this is not in rule, and we really believe things need to be in rule. So while we support this happening, we do have concerns about how it's happening. We will be watching it carefully. If there is an assessment that's inappropriate, we will be, when possible, we're not going to be able to do it for everyone, supporting appeals. There will be some people that have been getting skilled care and are now going to be assessed to need unskilled care that is appropriate. And let me explain that. There are a number of children who years ago it was known their care didn't qualify for skilled care. Now that doesn't mean it's not skilled. I want to be really clear. The rules that say what's skilled and what's unskilled are totally arbitrary and stupid in my opinion. But those are the rules that we have. For example, doing a G-tube feeding is skilled. Helping someone with a brain injury or schizophrenia clean their room is unskilled. I have personally done both, and the second takes way more skill than the first. But that's not what our rules right now and our laws say. Certain things are skilled, certain things are unskilled. So without judging, again, whether that's reasonable, we have to look at what the law says. So there are a number of children that years ago people knew what they were getting should have been unskilled. But because there was no way for family members to be paid because we didn't have community first choice, we've waited and just waited and waited. And now we have to move move those hours from skilled to unskilled. Unfortunately, that's going to mean a lower rate of pay for those people. It was good that the state did that because the alternative was having them have no option. Even though there is pediatric personal care, parents have reported to us that it is very, very difficult to use. And many of these pediatric personal care providers said that they would only provide care if the parent was in the house. And what parents said is, well, then why bother? It's just one more person to manage. It doesn't really give me a break. So this now has to happen. And that is going to be hard, but there's really nothing we can do if the care genuinely should be unskilled according to these rules. So that is one group that we will help explain, but we're not going to be able to file an appeal if the care really does not fit within the rules for skilled care. I have advocated for years personally, let's just get rid of the distinction. It just causes so much hassle, but I'm not in charge of this. So the nurse assessor process is something we are watching very, very carefully. And one of our concerns is about equity. If the way it's going to work is the nurse assessor's assessment is going to be a recommendation that goes to the case manager. Our concern is that people who either, have an advocate or their family's really savvy and they know how to get lots of documentation and write it up and hand it to the case manager to say, here's why I think they're wrong and here's what I need, will probably get what they need. The case managers do not have time, and this isn't their fault. This is the system that they live in. They do not have time to totally evaluate every single case. They're going to get a recommendation, and if there isn't something glaring, they're going to go with it because they have 8 million other things to do, and they have a computer system that doesn't work, so it takes them 20 minutes to find a phone number. They are not going to be able to second guess unless someone brings it to them. Our concern is that creates and perpetuates the same inequities that we've always had, which is the people that really know what they're doing get what they need and no one else does. And that's something that we're very concerned about. So we're really going to be appealing to people to help, even people who are just on these programs. When you learn the program, help your neighbors and friends and peers figure it out, because there also aren't enough advocates to go around either. So it's really up to our community to have as many people as possible learn this and figure it out. The other thing that's changing is, and I'm not sure, I think this is January, but I'm not 100% sure, is non-emergency medical transportation. That is a benefit for everyone on Medicaid to get you to medical appointments. So this isn't the long-term care benefit where like you can get the cab rides to go to the grocery store or day program or whatever. This is doctors, hospitals, therapies, all of those things. Right, what we've had is in the Front Range, we have a broker, and that's one company, and you call that company and say, I need a ride, and they find you a ride. Or you can't call, you have to use an app or whatever, but you reach out to them and they find you a ride. They also do mileage reimbursement for anyone in the state who gets mileage reimbursement. They used to be in the rural areas, but it was kind of it was an absolute disaster in the rural areas. So the state stopped doing it in the rural areas, but the counties that used to do it no longer do it because they want it out. So in the rural areas, it's just been people know who the providers are. They call their provider and they do it that way. And the statewide broker, they want to go back to a statewide broker. We do not agree with this, but it is probably going to happen. And the reason it's going to happen is, unfortunately, again, when some people abuse the system, it hurts all of us. There are some people, the providers, that abuse the system. They would go to Pueblo and put 10 people in their van and take them to a methadone program in Denver, even though there are methadone programs in Pueblo, and billed the state for millions of dollars, and the state had to spend a lot of time and money weeding those people out. It threw the whole system into chaos, and they're thinking they just need one group to manage it. We are very concerned about our rural providers because in the rural communities, people, again, they have relationships with these specific providers. we are still working through that and trying to get as much consideration in this for these rural communities as we can. I don't know that we're going to win getting them totally out of it, but we are working towards that. So that's just something else to watch that's coming. There is a transportation work group that is being formed by Rocky Mountain Health Plans, but every single Ray is joining it. So they are trying to work through these things. The other thing that is actually in rules coming up that we are trying to get changed is there's been a 25-mile rule that says you have to get prior approval to go more than 25 miles to your healthcare. Well, if you live in Denver, that's fine. You know, you can go 5 miles and find 100 doctors. But in some rural areas, there isn't a doctor or 25 miles, or there might be a doctor, but they can't see someone with a specific disability that you would have to, go farther. And I was in Alamosa last week and people were saying that there are parts of the San Luis Valley where it's an hour to get to a Walmart. So what we are asking is that they change in the new rules, they're saying going to 62.5 miles or 125 round trip. We are asking that the one way be 100 miles because we think that'll cover our rural areas and that any trip to Children's Hospital or university just be automatically approved because that's where most people are going when they're seeking specialty care. So we are asking for that. So,
Julie, we have questions about CFC. Do you
oh,
wanna?
absolutely. I'm sorry. Yes.
No, no, no. Alright, let me scroll it back up here. Um, is the payment of Medicare per A&E the same with CFC?
Yes, that is actually a Medicaid benefit. So anyone who has Medicare and they have full Medicaid, the Medicaid will pay your Medicare premiums, deductibles, and copays. Now, there's another program that's called partial Medicaid, and they're called partial dwellables, where if you're on Medicare and you're low income, you can apply for this program, and that Medicaid will pay your premium and sometimes also your copays. We don't have hardly any copays in Medicaid anymore, so that's kind of irrelevant, but it's the premiums that people care about. And so if Medicaid is paying that and it's through that other program where you didn't get into Medicaid through SSI, a waiver, or buy-in, then that's called partial dual, and that you wouldn't be on CFC if you're in that partial dual program. If you are on Medicaid, again, if you're getting CFC, you're on full Medicaid, you will have your premiums paid.
Does the state look heavily apply to CFC?
That's an excellent question and one the best I can say now, I can't give a definitive answer.
Um, Sorry, can we repeat the question? Sorry about that.
Oh, sure, no problem.
No, no, no. Does a state look heavily apply to CFC?
Yeah, let me explain what a state recovery is in case people don't know. So if you are getting long-term care Medicaid and you are over the age of 55, you are subject to what they call a state recovery. And what that means is when you die and you have a home or other things, Medicaid can take back what they spent on you. Now, if let's just say that you're married or you have an adult disabled child, or even you have a sibling that lives with you, and or really anyone who's living with you, and they've been helping keeping you out of a nursing home and doing your care, or if you have to sell the house, they're going to be made homeless. All of those people get hardship exemptions where they can stay in the house until they die, but eventually, then the house gets turned over to Medicaid to help recover the cost of what they've spent. So people can stay in their home, but then eventually it goes back. So, because Medicaid isn't inheritance protection. So it's not like I'm going to leave my home to my son who lives in Texas so that he can sell it and make money after Medicaid paid for my care for 20 years. So like you can't do that. But if someone's living with you, they can keep the home. So that is a long-term care benefit. So the question is a good one because if CFC is state plan and you're not using long-term care, then does does that qualify? And I've asked that question and I've not gotten super clear answers. I've gotten people have said, well, yeah, probably because it's still personal care, but I haven't gotten a really good answer from a lawyer. It's something I might ask our probate lawyer to research and give us an opinion on, because that would be a reason to get out of a waiver and only use personal care. So we will, but we can ask, we do have a probate lawyer on staff and we can ask him to do some research on that because we've not gotten a good answer on that, but that's a really great question.
That's the COC questions for now.
Okay, great. So we'll talk about advocacy action. So we just threw a whole bunch of stuff at you. So what do you do? What can we do as advocates? And when I say we as advocates, we see everyone in our community as a disability advocate, as someone who can speak up and advocate for people with disabilities, for yourselves, for your friends, for your families, for your neighbors, etc. So it's important now more than ever that we have lots of people involved. So what can you do? You can join the BASO councils. If mental health is something you're worried about, or substance use, or particularly people without insurance, because they're going to be more, you can join the BASO councils. There is a brand new program. They have nothing to go on. So setting them up, it's going to be important to have thoughtful, caring people that understand that we don't have unlimited resources, but also understand that we need to stretch every dollar, hold providers accountable, and use the money the best possible way we can. Join the Ray councils. Every Ray is already supposed to have a client council and a PIAC, and they all do. So you can join those, or you can join the second one if you're in an area where there might not be one. But you can reach out, and again, the contacts are in the links. You can reach out and say, I want to be part of this. Even if you don't get a seat on one of these, they're all open. You can go, if you're a client, you can go to these meetings. And most of them, I think, have a virtual option if you can't physically get there. Because again, some of these areas are really big. And so for many, many people, even when they are doing their best, you're not always going to have something really close. Read the contracts. It says read the Ray and Basso. I will also say read the case management agency contracts. You can go through these contracts, and there's a bunch that's legal gobbledygook that is painful to read for those of us who are not lawyers, maybe even for the lawyers too. But what you want to get to is like really what they have to do, like the scope of work. That's what you care about. Read them um, so that you know what they say. Report anything that isn't happening properly. And when we say report, well, you can certainly report to an advocacy organization. Sometimes we can't help you, but when we get reports of things, we often can bring it to the system, even if we can't address the issue. And particularly when we're hearing from a lot of people, it's often best to just go to the system and try and solve it than do a one at a time thing. But you can also report things to Medicaid, to the Behavioral Health Administration. You can report things to your legislator if you're not being listened to anywhere else. So please, if something doesn't sound right, report it. I had a great meeting today. Someone approached us and said that they'd gotten some directive that just didn't sound right. And it was about had to do with people with developmental disabilities who were living in their family homes, and they were told something that just made sense they couldn't do. So we had this big meeting, and we brought together the public health department and Medicaid people and this provider and other advocates. Turns out that the advice they got was, and other people in this region were getting the same bad advice. Turns out that they would be given bad advice. And now that we went to the state, they were able to say, no, here's what the rule is. The rule that they gave us was very reasonable. Here's what the rule is. And now they're going to go, tell them, no, you can't do this. And they also told us all what the rule is. And then said, here's the memos we sent out. Tell us what isn't clear. So sometimes it really is just people have to know that something isn't working. Sometimes it takes more than that. Sometimes we go to the state and they don't listen, and then we have to go to the legislature. But we want to always start with the state to say, is there a way we can fix this? So it's really important that people know if something isn't working. Share accurate information in the community. And if you don't know, it's okay to, I mean, I said I don't know several times tonight. There's a lot of stuff happening and no one's going to know everything. So it's really important that we don't share inaccurate information, because as rumors get spread, that's how things really fall apart. And it's really important that we make sure that the message about these programs that we care so much about, like the ability to have personal care, the ability to have who we want providing that care, whether it's a family or someone else, that we preserve all of those things. And when rumors get out and people start saying, oh, CFC is going to cause people to lose their Medicaid, or you can get paid $200,000 a year to take care of your kid. When those things go out in the community, that does huge amounts of damage. So it's really important that we are accurate about what we say, and that we provide good information. And learn about the nurse assessor tool and join our group. We will be following the implementation and assisting people. So someone asked, can we trust that case managers have been trained in all this? No, because case managers are human. HCPF has done training. Whether that training, when you're training a bunch of people, there are going to be some that don't get it. That's just going to happen. So I think that they are trying. I think that the people that are running the case management agencies are doing the best they can. And this is why we've got to report if something isn't right. So if you hear something from a case manager, I think most of the case management agencies, they really want to know. They want someone to say, hey, a case manager told me this. And if it was an innocent mistake, they will correct the case manager and they will retrain the case manager. And if it wasn't an innocent mistake, they will make a personnel change. So they want to know. They're not, my experience is not that they're getting upset when things are being brought to them. They want to know if something isn't right. A lot of them have also hired a lot of case managers. So think about coming into the system. Some of us have been around a really long time. Think about coming into the system, learning all of the waivers, now having to learn this, and all of these constant changes. There are going to be people that aren't trained. That's just how it is. The case management system has also been through a lot. They had a computer system thrust upon them that hasn't worked well. So it's important, and if you don't get a response from your case management agency, contact us, because we will get a response. We meet with them very regularly, and if someone is giving misinformation, we will deal with it directly. So there's
Yeah, it's people asking about the buy-in and the provider taxes. I promise, I know there's a lot of people nervous about the buy-in right now. We are nervous about the buy-in, like a vast majority of our staff are on the buy-in. So they're personally affected. I absolutely promise, folks, that we will have another one of these that is focused on the big beautiful bill, whatever we're calling it. And we are in a fight to preserve the buy-in. We're gonna have to get creative. I promise you, we will have ways to get involved that you can fight. We're just not there yet. Like, it passed on Friday. They literally changed it overnight, so they're still before they passed it. So they're still looking to get our arms around all of the implications. But I promise we're not just gonna let buy-in go away without a fight. I promise, I promise.
the other thing to know is that part doesn't go into effect for a couple years, so nothing's going to happen immediately. As far as we know, nothing, like, there shouldn't be anything happening immediately, and we will need all hands on deck to preserve this. We will need a lot of help, because it'll be whatever we figure out to do will be a big deal. And I think we're going to need that really to do. We're not going to be able to say there's going to be no changes in Medicaid. That's not realistic. We would never promise that. But I think to save as much as we can, we're going to need everyone to really help. And it's going to have to be a really big effort. It can't be a few people. But yeah, this is, preserving as much as we can is our number one priority, and that is not going to change. And we will probably be having, we'll have probably several more of these types of meetings. So again, we will have more town halls as we learn more. Please join us. And again, the link will be in what you get so that you get updates, because sometimes we might just have an update. It might not be a meeting. Please donate to support our work, to support us being able to keep doing this. And then please remember to come celebrate with us 35 years of the ADA and CCDC on July 25th. Okay, someone says, my sister says to tell Polis to use the $30 million for the bridge to nowhere on Medicaid. Message taken. Thank you all for showing up. I know it's a Monday after a holiday weekend, but we also know this is something that the community is very, very concerned about. And we will continue to keep, when we know something, you'll know something, and we will continue to keep everyone involved and informed. We will be sending out the recording and the slides and a link sheet in the next day or two.
And a quick just here's some info about sending out the slides. I know we lost some people, but there was